as the information as the information environment changes, we can see that the structure or the shape of the relationship changes, right? So when we have kind of mixed evidence, we see that there is still basically you're more likely as you get educated, but as you get to the top levels, you're maybe more able to discern some of the mixed information that's available out there. And when public information is full, accurate, and easily accessible, then more educated individuals in this full information period are less likely to get HIV/AIDS. So this was one of the first things we looked at when we tried to understand this relationship between education and health and how the social, political, informational environment might be shaping this relationship. So that led us to what we've talked about as the population education transition curve. So this is us trying to basically map or identify the functional form of this relationship over time. So the population education transition curve, or the PET curve, predicts the shifting education and health gradient across a population's exposure to new health risk. So how this works is that obviously our x-axis, we're looking at introduction of health risk over time, right? And the easiest way to think about this, and what I'd be interested in doing next, is looking at the COVID pandemic, right? So we have a new health risk that comes out. Over time, the information environment changes, right? And we can think about the relationship between education and that negative or positive health outcome from the exposure to the new health risk and basically across the weeks, months, and years following. The interesting part about this is that there's actually potentially multiple health risks out there at the same time in an environment. And so at some times, education might be protecting an individual or providing a vaccine effect from one health risk and actually having a risk factor for a different health risk. So you can imagine that there's multiple kind of overlapping PET curves, if you may, on this. So we are looking at, this is basically easiest to understand as kind of a log odds on the y-axis, where a positive log odds is associated with an increased health risk, and a negative log odds is associated with a decreased health risk, right? So we can imagine above zero being education as a risk factor and below zero representing education as a social vaccine. Okay. What we're most interested in here is actually where does it reach zero? Okay, where is that social vaccine point? So this is kind of our hypothesized PET curve. And we wanted to go away and say, okay, are we able to illustrate this in some of the other health exposures that we see in the literature? So we remodeled some of the prior studies. So this is one that was originally from DeWalk, looking at the relationship between education and smoking in the US. Okay. So again, zero is the point where there's no impact. Above zero means education is a risk factor. So more educated individuals are more likely to smoke when it's above zero and less likely to smoke when it's below zero. So here we do a couple things, because there's, in addition to information periods, there's also a prevalence effect, where as the prevalence of smoking or potential health outcome increases, we have greater awareness of it. We are also more likely to get accurate information as we pay more attention to it. So here we map not just information periods, but we also look at cigarette production. Okay. The other interesting bit about cigarette production, and we see this also when we look at smoking in China, is we see that material benefit of education being there early when cigarettes are rare and relatively more expensive. So at that time where cigarettes are rare, production is low, and information really isn't available in the US, 1940s, early 1950s, we see education being a risk factor. So more educated individuals more likely to smoke. And through kind of three main periods of improving information, we see changes to log odds. And so we start with an epidemiological evidence report being published, and then about a decade later, we have the first US Surgeon General report. And then in the US, in the early 70s, there's mandated packaging warning on cigarettes. And as the information period improves, we see that education and the relationship between education and smoking changes from a risk factor to a social vaccine. And that's now what we see as the expected bit in the UK and the US, that more educated individuals are less likely to smoke. But that wasn't always the case. A different example is this is from Latin America and the Caribbean, and looking at the relationship between education and being overweight. So we're looking over a larger time period. So this is thought about as a nutrition transition. The nutrition transition, if you're not familiar with it, is the percentage of diets that are in high fat, high sugar, processed food. Okay. And generally speaking, as we go from primarily farming communities to more industrial communities, we see an increase in this type of processed high fat diet. So this is moving towards a more processed high fat diet. Okay. And you can see that early on, where there was more reliance on, let's say, agriculture and locally grown food, and this type of, let's say, McDonald's effect was rare, then we had education working as a risk factor. Okay. And as they moved along and it became more ubiquitous and there was more access, probably prices were driven down, then we see education acting as a social vaccine. So at the end of the nutrition transition, more educated individuals are less likely to be overweight and obese. This is the background on the PET curve and how we've seen it so far. So we also did a prior meta-analysis looking at the relationship between education and chronic disease. And here, although it wasn't our original focus, the results suggest that there was a PET curve present here as well. So when we look across the epidemiological transition, okay, so the epidemiological transition is the development transition basically towards older age, so where individuals live longer and longer. And we see that countries that were further along in the epidemiological transition with a life expectancy of either 70 or 75 or 75 and older, education was a social vaccine. So more educated individuals in these countries that were further along in the epidemiological transition were less likely to be impacted by chronic disease. In countries with life expectancy were under 70, there was no relationship. So this started us thinking about, is there a full curve here? Is it a half curve? What does it actually look like? We can imagine that part of this is countries aging into chronic disease. Right? Chronic disease doesn't hit until later in life for a lot of people. It's more likely to be there for older ages. And so this is what some people have talked about as a double burden of countries from the global south, not just having higher rates of infectious disease, but as they age, also aging into chronic disease. So having this double burden of health. So that's the prior meta-analysis, and this is basically the basis of the current study. So what I wanted to do with this study is just to think about what factors actually influence the time in which a country reaches the social vaccine point. Okay, so this is our curve from previously. And I just wanted to point out that zero, log odds of zero, means that we're shifting from education as a risk factor, so education above zero, or log odds above zero, to education as a social vaccine, which is anything below zero log odds, right? So I think that point is really important when we think about what are the implications for how we treat individuals, what our interventions are for healthcare, who are we targeting. But that social vaccine point becomes really important. So I want to know what factors influence when a country hits that point. So for the study I'm going to talk about today, we'll probably just have maybe 10 minutes or so on this. It is a random effect meta-regression, which extends, sorry, it should be extending the meta-analysis from previously. Okay, so we did a meta-analysis. We're looking at a meta-regression. The meta-regression allows us to predict an outcome. So we're looking at actually the gradient itself. So the impact of education on chronic disease based on the additional study characteristics. Okay. So some of those study characteristics are already included in the meta-analysis studies, but we're able to add additional country time-specific context variables to also capture some of these important environmental factors. So that included the economic development of a country when that data was collected in that country. And so that's captured from GDP per capita. We're also looking at the national education level of the country when the data collection was done in that study. That is mean education years. And then also looking at the population structure. So since we're looking at education chronic disease, following the meta-analysis, it made sense to look at life expectancy. And we also looked at the percentage of the population over age 65. So this follows an underlying meta-analysis, which you can see in our earlier paper in Social Science and Medicine. This is officially the data of our meta-regression. So the meta-analysis included articles between 1990 and 2010. Our search terms are education and a combination of chronic disease, risk factor, and health behavior. At the end, we ended up with 40 studies and just over 400 independent effect sizes. And we had 37 country time pairings. Okay, so that might mean there's a United States study from 1992, that'd be one country time pairing, and a United States study from 1998 would be a different country time pairing. So the overall effect of education and chronic disease in this meta-analysis was about a 16% reduction in the likelihood for those with the highest levels of education would be basically impacted with a chronic disease. And we also looked at it by different types of chronic disease. And the only one that was, you see at the bottom there, that was non-significant was neoplastic, and most is because that tends to be hereditary. So this is our underlying meta-analysis. And we are using this data to perform a meta-regression to try to see if these other contextual factors of these studies have a relationship on the association between education and chronic disease. So the first thing we do is just look at some descriptive bubble plots. So these are, you can think about them as just like regression lines, just a bivariate analysis. So on the y-axis is the log odds ratio. So this is the education chronic disease gradient. So a positive means that it's increasing it's pointing education and chronic disease towards a risk factor. And a negative log odds means it's moving it more towards a social vaccine. So here we're trying to think about, is the economic development of a country associated with this relationship? We're looking at GDP per capita, and we see basically a flat line here. Okay, so this suggests that there's not really any difference between the level of economic development of a country and the education chronic disease gradient within that country. And if you're not familiar with bubble plots, the size of the circle is basically around the precision of the estimate, and each of these dots represent specific individual points. So those 418 points I talked about previously. We go to mean education and education chronic disease gradient. We see here slight negative but significant relationship where individuals with greater levels of schooling are more likely to see a social vaccine effect between education and chronic disease. When we look at life expectancy and education chronic disease gradient, we see basically what the meta-analysis suggested, that individuals in countries where the life expectancy is higher, individuals with more education are more likely to be uh, benefiting from that. So that we see more education leading to a social vaccine in these countries with greater life expectancy. And we see a very similar figure if we look at the population and the percentage of the population above age 65, right? And that shouldn't be a surprise because life expectancy and the percentage of population above age 65 are really heavily correlated. So these are just bivariate descriptives. There's no controls on this. So the next step in a meta regression is to run a regression. So here we have a random effects meta regression trying to predict the gradient from these different contexts. And we start with a null model, right? So there's no control variables. We don't control for country or time either. And what this does is it gives us basically a number down here, the 0.148, which represents the percentage of variance explained by between study characteristics. Okay, so about 15% of the variance in that gradient is explained by between study characteristics. And then we're just adding variables as we move to the right. So the first thing we add in model one are controls for country and time. So here we can see that about 30% of the variance is controlled by or is captured by just recognizing that the country that we have in that study and the time for which the data was collected. And then we move to the variables of interest for us. So our independent variables, starting with GDP per capita, we can see a very small and positive effect, which is interesting. But our adjusted R squared, which is the percentage of original variance captured in this model, actually goes down some. And it looks different than our bivariate relationship. So we're not entirely sure what to make of this at this point. When we add expected years of schooling, GDP per capita changes. It goes to a negative, suggesting that basically a lot of the attention is driven by schooling and not necessarily GDP per capita. And when we look at the adjusted R squared, we see a sizable jump in the variance explained. So I'm much more confident that expected years of schooling has a significant effect and that this expected years of schooling, similar to what we saw in the bivariate, is associated with an increased social vaccine effect of education on chronic disease. So in the final model, we put all variables in to try to force them to compete for explanatory power. And here we see a small negative and significant effect for GDP per capita, a similar size coefficient for expected years of schooling. We see life expectancy being significant and negative. So again, individuals in countries with higher levels of life expectancy, more educated individuals are less likely to have chronic disease. And we see a non-significant relationship between the percentage of the population over age 65. But again, I think that's basically just due to the correlation between life expectancy and the percentage of population above age 65. And we see this final model does explain the most of the between study variance at just about 36%. So these are our overall results. But what does this mean? So again, this is log odds. So a decreased log odds of 0.5 is substantial. But to give you an apples to apples comparison, so a 0.5 point decrease in the chronic education or chronic education chronic disease gradient, sorry, is associated with just over 2,000 US dollar increase in GDP per capita. Oh, also at the same time, a 1.2-year increase in the mean education level of the country, or a 2.2-year increase in life expectancy. So I focus on education, so I'm wanting to know and make more sense of the mean education effect. One thing that we did see in the literature and almost expected to find here is what has been talked about as a diffusion effect, right? And this is almost like trickle down education, where more educated individuals are going to benefit society as a whole. Um, but that wasn't really supported. If we saw a diffusion effect, we would have expect the education chronic disease gradient to go towards a null effect where there's not that inequality, right? Instead, what we found was in more educated systems, there's increased inequality. So more educated individuals are actually more likely to see it as a social vaccine, and less educated individuals see it, have it definitely more as a risk factor. So part of this is education is really a master factor in social stratification, right? Very important for social reproduction. Um, some of our early thinking is that the increase in the mean is actually due to transition at the higher end of education, where we have more and more individuals going on to university education, and there's a larger gap between that and those that are still getting very low levels of education. Okay. So we have people that were completing secondary now completing tertiary, but we still have about the same percentage of individuals completing only primary. So there's an increased gap there because the transition's due to the higher end. And what this does is just exacerbates the differences. So a larger percentage are now in the high income category, and those in the lower education category just continue to fall farther behind. So what does this mean for the PET curve? The arrow here is a little bit, I think I need to change this a little bit, because what actually happens here when we have increased in mean education is the PET curve gets pushed down, right? Because we have a negative impact on the log odds. So the PET curve gets pushed down. And what that does when we push the PET curve from the solid line to the dashed line is that it actually shifts the social vaccine point to the left. So there's now an expectation that education is going to start acting as a social vaccine earlier in the exposure to this health risk. So that's what we think is happening with the PET curve when we have more educated countries. So it's important to us to recognize that the PET curve is itself an illustration of inequality, right? But so, shifting this curve doesn't actually mean that there's a null impact. There's still inequality across the exposure to this health risk, but there's some benefits to moving it to the left. So the first is that it raises the general level of education, right? So there's benefits to increasing education. One is it raises the general level of education, which basically likely increases the number in the more educated groups. So while the, let's say, log odds changes and we see increased inequality, the potential number that benefit might be greater. It also, as we move towards an earlier social vaccine point here, and we have more individuals in the high income or high education group, the high education group, we might be able to redirect resources and interventions to those that need it the most earlier. So final slide here is just thinking about future questions for the PET curve. There's still things that we're trying to understand, work out here. And some people have done some interesting research around this and helped us understand this, but there's still a long ways to go. So just from this meta regression, we need to think about, does the PET curve maintain its form in a country over time, or do changes in the education level not just shift the social vaccine point to the left, but also change the shape or form of the curve? We need to be thinking about the distribution of increased education, right? So based on some other research I've done, I think that the distribution in the mean education is from secondary to higher education, with basically the same percentage hanging around in primary, but that may not actually be the case, right? So how does the distribution of increased education across a country shape the impact of mean education on the curve. And finally, this is still pretty new. So the more we can look at this with other health risk, the more likely we're going to be able to see if this holds, when it holds, under what assumptions and circumstances does it hold. So is the PET curve present in exposure to all health exposures? I haven't done this yet, but I'd be quite interested in looking at COVID on this, because I think we saw improved information across really the first 6 to 8 months of the COVID pandemic. We probably saw differences in expected social vaccine or risk factors for education as that informational environment changed. Okay, so that is it for me. Um, yeah, really thankful for everybody for being here today. Looking forward to any questions. If you want to get in contact with me, my email is on the screen. So thanks, Fiona and Mubarak, for inviting me and yeah, taking the time.